Post ESMO 2025, the amount of data that came at us in the world of cancer is overwhelming, to say the least. A common theme has been the use of immunotherapy in earlier stages of cancer, be it lung cancer, gastric cancer, or even bladder cancer. Good morning, everyone. Welcome back to the Oncology Brothers podcast. I'm your co host, Rahul Gosain, here with your another host and my brother, Rohit Gosain.
Hello, everyone who's listening in. In general, the theme for any tumor type has been if agents are working well in later lines, well, bring them into the first line therapy. And that's exactly the story with IO in non-muscle invasive bladder cancer space. This is also making the partnership between SurgeOnc and RadOnc even more important along with medical oncologists. In general, the med-oncs have had little role in non-muscle invasive bladder space. But post-ESMO, we are seeing medical oncologists in this earlier stage, that is non-muscle invasive bladder cancer. In today's challenging cases discussion, let's apply the data that we recently saw into our real-life scenarios. And for this, we are excited to have Dr. Joshua Meeks, a urologist from Northwestern University, and Dr. Shilpa Gupta, a medical oncologist from Cleveland Clinic.
Josh and Shilpa, welcome. There's a lot to unpack in non-muscle invasive bladder cancer. We have two cases to touch on, which will give us a chance to cover the recent data. Let's start with a 71-year-old gentleman who's a former smoker. The workup showed a multifocal papillary grade 3, high grade, but there is no muscle involvement. Before we get into our treatment options, Josh, what qualifies as high-risk non-muscle invasive bladder cancer?
Well, thank you, Rahul. I'd say that, so this patient is our classic high-risk bladder cancer patient. And what qualifies him for that, in that he's got a grade 3 or a high-grade tumor. It's multifocal. So, in general, this is a patient that when we see in our practice, very clearly, you would probably give that patient a year of therapy at least. Our guidelines, which were almost written a decade ago, would recommend 3 years of therapy. But again, because of the supply shortage, we don't always have that. But you'd want to give them a year of therapy. And again, I would quote this patient probably in the neighborhood of a 76 to 78% chance that at 3 years, they would be cancer free, and a progression risk to muscle invasion, like, 1 to maybe 2%. So pretty low progression risk, but high risk of recurrence.
Absolutely.
Indeed, and these are the patients that we need to be cautious about. These patients can be in complete remission, and we don't have to utilize further therapies.
Yeah.
Shilpa, during our fellowship training, I don't think any of us was thinking that medical oncologists will be part of non-muscle invasive bladder cancer space, but here we are. Well, we have been using pembrolizumab in refractory carcinoma in high-risk patients. What we are also seeing is IO plus BCG lately, especially after post-ESMO. In this space, BCG alone for high-risk patient is not good enough. Shilpa, could you please briefly touch on what data you have for IO and BCG as per the recent trials?
Yeah, this is really exciting times for us to partner with urologists in this space, which honestly, until the Keynote 057 trial was being done at University of Minnesota, I didn't even know the definition of BCG unresponsive NMIBC. And I used to screen patients for that trial. I would say that BCG has been a very effective therapy for decades. And now we are seeing that when you add IO to BCG, some patients may benefit from that addition, and I would love to have that discussion now. There were two trials, the CREST trial, which is the BCG plus sarilumab, which is for 2 years systemic immunotherapy versus BCG maintenance and induction. That was the group B. And then there's the POTOMAC trial that we saw at ESMO, which is BCG plus or minus 1 year of durvalumab. And there was another trial called the ALBAN trial, which was a European-led trial. Unfortunately, in that addition of atezolizumab did not show any benefit, while these other two trials showed benefit in terms of recurrence.
I think, as we counsel these patients, people often ask, what's the ideal patient to consider here, right? So again, these were all high-risk patients. So they all had high-grade tumor, TA, T1. Some of them had CIS. The amount of CIS varied between the trials, but they were very similar trial designs, right? They're all 3-arm trials. Other than ALBAN, which everyone got a year of BCG, both CREST and POTOMAC both got 2 years of BCG. The difference in the duration of IO, which Shilpa can talk about the potential impact of that. But I think, again, these are all patients that in general, urologists, we would give them BCG alone.
BCG. Shilpa, Josh, thanks for touching on that. A few things to reiterate here. You started us off saying majority of these patients do well with
Right.
BCG. But
Yep.
again, majority of the patients that are today diagnosed with bladder cancer are still in non-muscle invasive disease.
Yep.
So the number of that impact is significant. As a medical oncologist, I'm only getting involved historically when this was muscle invasive. But majority of the burden with this disease is indeed with non-muscle invasive bladder cancer. So no matter how we look at it, medical oncology will play a bigger role. And then Shilpa, you touched on CREST and POTOMAC trial. 2 years of maintenance with CREST, with POTOMAC, there was 1 year of durvalumab. Josh, coming back to this patient in front of you,
Yeah.
if all this becomes available, how is that conversation going to look? How do you envision partnering with medical oncologists? What will be the right treatment moving forward?
If you look at the subgroup analysis, the forest plots, there were some subtle differences. Like clearly, Potomac was a T1. They did better. So actually, sorry, both Potomac and Crest, the T1s did better with the checkpoint. There's a benefit for CIS in Crest. But I don't think that's necessarily how we'll select these patients. The way I think about them is, what are the patient's goals? Because we're not
Absolutely.
improving survival in either one of these trials. So it's not like you can make the argument that if you give immunotherapy, you're going to decrease that small number of patients that are going to die from non-muscle invasive bladder cancer. It's really about event-free survival. So if you have the discussion with the patient and say, okay, I can get you to 76 to 78% with BCG alone, is
Yes.
that absolute increase of up to 82 to 83% with checkpoint, how much does that matter for you? And some people, it will. If you want everything, and we have those patients, that's the expectation. This is your first chance, best chance to do that, but it's going to come at a potential risk of toxicity. I think the alternative is they get BCG up front, and if they recur, we now have 5 drugs in the BCG unresponsive space. But a lot of people are going to want best in class, and I think we've shown a superior benefit for event-free survival.
Right, and thanks so much for stressing that, Josh. Event-free survival is what we are looking at. But again, we see a lot of these patients, as you stated, that at the end of the day, patient will still ask, Doc, what would you do at the end of the day? Shilpa, at this point in time, how is that conversation happening on your end? Are you the one making that decision for immunotherapy, or urologists are treating? Who's managing the toxicities and everything?
So, right now we are not yet seeing these patients. I can speak for patients who come in for single agent pembrolizumab. We're not really getting a lot of referrals for that from urologists per se. Those are the motivated patients, like you're saying, who read up about stuff. What are the options to preserve my bladder? And then they go and get an appointment with a medical oncologist if their local urologist
Right.
has not offered it. So we're seeing very limited patients for systemic immunotherapy right now. We are the ones who will manage the side effects since we administer it. If these regimens move in the BCG naive setting, I think we will be the ones seeing these patients and managing the toxicities.
Indeed.
I don't want to speak for the LUCPA practices. They have the resources where I think the urologists have the resources to have advanced practitioners who can manage and administer. So that's a different story. But I think for
Indeed.
the most part, medical oncologists will need to be a part of the decision making and managing the patient. And really, the message is not that subcutaneous is just easy peasy. The message should be that that is as toxic as IV, and you
Right.
really need constant monitoring.
Yes, we'll certainly jump on the toxicity. Josh, anything to add there?
I think it's a good point that Shilpa brings up, is that up till now, she was seeing referrals almost as an alternative to cystectomy, right?
Cystectomy. Yep.
So it was almost like they saw us, we recommended cystectomy, and then they didn't want that. Now it's more of, we're going to have to do this together.
Yes.
Because this is frontline, and it's not like we're offering BCG or checkpoint. It would be more of like, okay, this is an option for you. If you're interested, we should have you meet with Dr. Gupta to talk about what this would be like, because it's going to be a risk benefit discussion of potential risk versus potential toxicity. And I think that's a very nuanced, individualized discussion. And like you said, the numbers are astronomical, right? If you look at all of bladder cancer, 80% of it is NMIBC, and probably 75% of it is high grade.
Right.
Yep.
So it's going to be a large number of patients in the neighborhood of 40 to 50,000 patients a year potentially could be candidates for this therapy.
Indeed, medical oncologists will have to have a lot to say, especially after the results, what we're seeing. And also to that particular patient population where, as you mentioned, Josh, they are saying that they do not want to undergo cystectomy. And that's exactly what the second case is all about. That is a 74-year-old woman who's ongoing tobacco abuser, known history of non-muscle invasive bladder cancer with bulky tumor of about 4 centimeter solitary papillary tumor that was detected about a year ago, did undergo BCG times 6. But again, prior BCG exposure and now presenting with another non-muscle invasive bladder cancer, and she wants to preserve her bladder. Josh, with her prior BCG exposure, can BCG plus IO still be an option? Could you please walk us through your treatment scenario here?
So this is a different case we don't necessarily have data on. This is probably closer to your Keynote 57 trial scenario. We have a trial very similar to this. It's Keynote 676 Cohort A, which is testing this specific kind of patient where they were BCG exposed. I mean, this patient is truly BCG unresponsive because they were, it looks like T1 they got 6 and became T1. So we usually move them onto a BCG unresponsive regimen, and the only data we have that an IO can rescue them is the Keynote 57 data. In this case, I'm not truly supportive of that data only because the response rate to Pembro is about 40% at 3 months, and 40% of those people
Right.
are in remission at a year. So it ends up being only 19% of the starting cohort. I think we have other therapies for BCG unresponsive patients. I personally would probably think about a bunch of other therapies in this setting, but I think there's a lot of people who will probably look at the naive setting data and say, okay, I didn't give it before, we got a boost from it, so now we should consider it. And I think there's a little bit of danger in that data, again, because we've not shown, and pretty mature data in POTOMAC, that we haven't had an improvement in progression or overall survival, which this patient's a little bit at risk for.
I have a question here. Isn't it true that once BCG refractory, always BCG refractory? I've seen that several places. I was wondering, because, we see that in medical oncology all the time, right? People have progressed on IO and now they have metastatic disease. Everybody wants to give EV Pembro. We really don't know if that's the right thing to do or
Right.
not. So I was curious what you think about the BCG refractory.
Yeah, it's a bit of a controversial dogma, right? So Ashish Kamat kind of came up with that saying, like, once BCG unresponsive, always BCG unresponsive. That probably has something to do with the bladder or the patient's ability to respond to BCG. But in a certain degree of patients, we have a sense that they get to BCG unresponsive because they have exhaustion. Now, this patient didn't really get much BCG, and then they already had a T1 recurrence. So whether that's the BCG not working or the patient just has really aggressive cancer, it's hard to know. I think in general, to your point, I don't know that I would necessarily think that BCG would be the best therapy in this patient, but I also think that giving single agent checkpoint doesn't work well. So, you're taking, I think of it as like if you're adding BCG, you're adding more flame and then you're throwing gas on it with the checkpoints. So there may be a benefit there, but I would probably move to a different drug instead of thinking checkpoint is my first option. I mean, what would you think, Shilpa, if this patient
Yeah,
saw
I
you?
think there's like a wide array of options available to us now. So I would not favor pembrolizumab for this patient.
And if this
You know,
patient was BCG responsive and it had, instead of 1 year, rather 2 years, would you then utilize BCG as a single agent or rather combined with IO therapy at that point in time?
So it depends how long it's been since they've last gotten BCG. If they got BCG and then a year later they show up with a new tumor, that's when you could have that new discussion about, okay, we gave you some, you had a good disease-free interval.
Right.
Now we're basically starting again, but now we have more data. You've already experienced this once, so it may be worth thinking about checkpoint. I would say probably has more to do with the 74-year-old and how much all of that would sort of play into Shilpa considering giving them therapy. Whether they get checkpoint or not, it's hard to say if that's really going to benefit them. But if they had a year of disease-free interval, I think I'd probably challenge them with BCG again.
none of this is black and white, be it our data from immunotherapy saying the time frame or here with BCG. There's a lot of gray here. There's this risk versus benefit ratio that we have to keep in mind. So Shilpa, let's bring that conversation back here, the side effect profile. I would like to think that a lot of urology colleagues in community settings will at least start thinking if they should be the ones to prescribe immunotherapy, be it Pembro or these combinations with CREST or POTOMAC here. Can you touch on some of the common side effects that we have to keep in mind with immunotherapy and some clinical pearls around that?
Yeah, absolutely. And, we all treat these patients day in and day out, not just with bladder cancer, but kidney cancer and other cancers. I tell the patient that it's a really head to toe, anything can happen. And not to scare the patient, but just so that they are aware that if all of a sudden they're very tired one day, it's not normal. They need to seek help. We have to rule out adrenal insufficiency, pituitary insufficiency. Then, if they get short of breath, it could be pneumonitis, and not to sit on any complaints, anything out of the ordinary, we need to know. If having more than 3 to 4 loose bowel movements a day, if that's happened, we
Right.
need to know. Muscle aches, joint aches, shortness of breath. I mean, most of these are not life threatening if caught in time, but we have seen and lost patients to really severe things like
Yes.
myocarditis. If that patient is not started on steroids before it gets worse, we will lose our patients. I think
Right.
that's a very important thing, because when I think about the patients calling in the middle of the night to a medical oncology practice versus a busy urology practice where they're dealing with stones and urinary
Everything.
retention, and then somebody calls with shortness of breath, I just think that can get lost in other things. They'll have to triage the patient, go here, go there. Josh can speak to this. The urologic problems, you'll know what to do and get in the procedure room. But I think our patients really need a lot of hand holding. I tell them, you go to the emergency room, show them you are on this treatment. Like, there's a whole
Yeah.
set of stuff we have to do
Right.
for
Absolutely.
especially our older patients who are not even telling us the problem. I'm sure it's a learning curve, and eventually
Yes.
with the good partnership, the urology practices will also become,
Right.
we also learned this
Right.
along the way, but I think really need to partner with a lot of specialties too, not just med onc, but you need to have a GI person handy, a rheumatologist, pulmonologist. So if the practices have all those resources, I think it will be easier.
I would say similar to what you said. I think it would probably take 2 generations of urologists, meaning that like our generation would have to learn how to triage the side effects, like when to look for them and how to manage them. And then we have to teach the next generation
Right.
that so that they, as they come in, it becomes part of them. So it would probably be 2 full generations of surgeons to learn that technique. Now, it doesn't mean that it's not feasible. And I honestly think from a supply and demand, there's not enough medical oncologists to manage the number of patients
Indeed.
potentially that would benefit. But I also think that that transition may be a little rocky as we go from one to the other.
No, it is a team sport at the end of the day, and I feel like there has been some notion about like IO is better tolerated than chemo. Yes, that is the case, but Shilpa, as you stated, with the side effects, rash, diarrhea, hepatitis, and some of the immune-related rare side effects, we have lost patients because of this. That is myocarditis and encephalitis are some of the serious one. Well, thankfully, these are rare. Before we get to the ending here, Shilpa, with regards to metastatic space, how we have FGFR mutation testing and drugs available in metastatic space, any role of that in earlier lines or non-muscle invasive, any trials ongoing, anything from NGS standpoint that we need to be aware about?
Yeah, and that is a really great question, because we see that in the earlier settings, there's more upregulation of FGFR. In the metastatic setting, is just 10 to 12%. Like, I can literally count how many patients I have on a systemic FGFR inhibitor right now, maybe two. But in the NMIBC space, we see more, and that's where the intravesical therapies come into play, because we've already seen systemic trials with erdafitinib were really way too toxic
Right.
and terminated before accrual could be done. Josh could correct me if I'm wrong. But there's the Moonrise trial where there's this device you put in the bladder, and instead of gemcitabine, it has erdafitinib. So that's very exciting to me as a non-urologist too.
No, you're totally right. So Moonrise 1 is TAR-210, the erdafitinib releasing device. It's a Q3-month device. It just closed Friday. It was compared in the intermediate risk setting, so those recurrent low-grade tumors where the frequency of alteration is 60 to 70%. Could be detected by urine, could be detected by tissue, and that all of that was allowed in this trial. It's versus either intravesical gemcitabine or mitomycin. I think we'll have the results from that relatively soon, but excitingly, it was just closed Friday. And then Moonrise 2 is a very exciting trial. So that is intermediate risk tumors agnostic to mutation status, and the patients get treated with TAR-210, and then we check and see what their mutation is. So it'll be very interesting to see, again, because we think that there's activity of the therapy even in the unmutated population. So it could be super interesting, and a lot's coming in this field.
As we wrap up, Shilpa, any closing thoughts in this non-muscle invasive bladder cancer space?
I think it's a really great times, for our patients to have these options for getting effective therapies earlier on, and we will start partnering much more with our urologists.
Josh, any final thoughts for our listeners, as we will likely see more of these patients in our clinic, which is going to be non-muscle invasive bladder cancer?
No, again, I think you really have to start thinking about bladder cancer as a team sport, as you mentioned. We do that already in the muscle invasive space. We're going to be doing that more in NMIBC. So again, this is an oncology space that it's rare to do as a solo effort. Again, I think this is a chance to partner to help our patients out.
Well, we have covered a ton in rapidly shifting landscape of non-muscle invasive bladder cancer. And as Josh and Shilpa, you both alluded to, that's what I'm walking away. That multidisciplinary approach is going to be the key. Discussing these patients with medical oncologists and urologists is going to be very critical. Josh and Shilpa, thank you so much for sharing your thoughts and tying in the most recent data that we have seen in this space. For our listeners, let us go over a quick recap. In today's discussion with Dr. Joshua Meeks, a urologist, and Shilpa Gupta, a medical oncologist, we touched on the treatment approach in non-muscle invasive bladder cancer. Historically, medical oncologists have very little role to play in this particular setting, that is non-muscle invasive bladder cancer, but that's no longer the case. Rahul, your key takeaways from today's discussion.
Rohit, to me, post-ESMO 2025, we can see that immunotherapy is moving in earlier lines of disease, be it through POTOMAC trial, where durvalumab is for 1 year maintenance, versus CREST, where sacituzumab, yet another immunotherapy, is for 2 years maintenance. But the data looks very similar. Here in non-muscle invasive space, Rohit, we also have TAR-200, which was recently approved. Talking with our urology colleagues early on is going to be the key. However you slice or dice it, non-muscle invasive bladder cancer management now will demand a team approach. Rohit, anything you want to add here?
Right, exactly what Rahul you're saying about the team sport. That's exactly what Josh and even Shilpa agreed with. With regards to also what Shilpa mentioned is that IO has side effects related to it. It's not a benign therapy. So again, keeping these side effects in mind and how to manage them is equally important. We hope this was a fruitful discussion. We appreciate you tuning in. Check out our other episodes for more practice-changing data from the oncology world. We are the Oncology Brothers.